Good morning, students. So today we will discuss about the cerebrovascular accident. So what is cerebrovascular accident? So the cerebrovascular accident or the cerebrovascular diseases include the most common devastating disorders. So they are the three most common cerebrovascular accidents. They may be in the form of ischemic stroke, hemorrhagic stroke, and third is the cerebrovascular anomalies. These cerebrovascular anomalies can be in the form of intracranial aneurysm or in the form of arteriovenous malformations. So most of the cerebrovascular diseases manifest by the abrupt onset of a focal neurological deficit. So in the cerebrovascular accident, there will be a sudden onset of a focal neurological deficit. So we will learn about the definition. What is cerebrovascular accident? So the cerebrovascular accident may present in the form of cerebrovascular anomalies, ischemic stroke, or the hemorrhagic stroke. So what is cerebrovascular accident or the stroke? So in the normal common nomenclature, it is known as the stroke. So what is cerebrovascular accident or the stroke? It is the abrupt onset of a neurological deficit which is attributable to a focal vascular cause. So there will be a sudden onset and there will be a neurological deficit and it will be attributable to a focal vascular cause. And how will you diagnose the cerebrovascular accident or the stroke? You require some laboratory studies and the brain imaging. And clinical manifestations are highly variable because of the complex anatomy of the brain and its vasculature. But the presentation is very variable because the anatomy of the brain and its vasculature is very complex. So we now so the most of the patient either present as a ischemic stroke or the hemorrhagic stroke, and in majority of the cases it is the ischemic stroke. So the ischemic stroke, it is much more common than the hemorrhagic stroke. Around 85% includes the ischemic stroke and rest 15% is includes the hemorrhagic stroke. And in the ischemic stroke, our main focus is on the administration of recombinant tissue plasminogen activator or endovascular mechanical thrombectomy. So the ischemic stroke is due to the occlusion of the vessel which is producing the cerebral ischemia. So our main focus is either on the thrombolysis, which is a medical treatment, or it can be some invasive treatment in the form of endovascular mechanical thrombectomy. And in hemorrhagic stroke, they are usually caused by the hemorrhage, and here the BP lowering is the primarily concerned. So the hemorrhagic stroke is usually caused by the aneurysmal subarachnoid hemorrhage or the hypertensive intracranial hemorrhage. So most of the patients of stroke or the cerebrovascular accident may be grouped into either the ischemic stroke or the hemorrhagic stroke. Now we will discuss first the ischemic stroke, then we will discuss about the hemorrhagic stroke. So if we go for the pathophysiology, how the ischemic stroke occurs. So there are the three major mechanisms through which the ischemic stroke can occur. So what is the mechanism of ischemic stroke? So there are the three major mechanisms. First is the embolization. So this embolization can arise from the heart, or it can be the intracardiac embolization or it can be the extracardiac embolization. So any emboli either going from the heart or going from above the heart to the brain and it producing the ischemic stroke. Second mechanism is the thrombosis. So whenever in a intracranial vessel a thrombus develops, it leads to the occlusion of the vessel and it produces the ischemic stroke. Second mechanism is the thrombosis, which is occurring within the intracranial vessel. And third mechanism is the hypoperfusion. This hypoperfusion can be due to stenosis of an intracranial vessel or it can be a extracranial vessel. So whenever there is a occlusion or stenosis of the intracranial or extracranial vessel, it produces the hypoperfusion in the cerebral parenchyma and it produces the ischemic stroke. So these are the three major mechanisms of producing the ischemic stroke. It can first is the embolization, second is the in situ thrombosis, third is the hypoperfusion. And how will the ischemic stroke occur? So there are the two pathways of focal cerebral infarction. So first is the necrotic pathway and second is the apoptotic pathway. In necrotic pathway, there is rapid cellular cytoskeletal breakdown due to the energy failure of the cell. So there will be the necrosis of the cell leading to the ischemic stroke. And second mechanism is the apoptotic pathway. Here the cells are programmed to die. So these are the two pathways of focal cerebral infarction, that is the necrotic pathway, and second is the apoptotic pathway. Now come to the etiology, how the ischemic stroke occurs. So the mechanism we have learned that it can be due to embolization, thrombosis or the hypoperfusion, but what are the causes which can lead to the ischemic stroke? Although the initial management of the acute ischemic stroke often does not depend upon the etiology, establishing a cause is essential in reducing the risk of recurrence. So why we are bothered about the etiology? Because all the management of the ischemic stroke, when a patient comes to you with a ischemic stroke, the management is similar regardless of the etiology, but establishing a cause is essential in reducing the risk of recurrence. And our main focus is on two things. First is the atrial fibrillation, second is the carotid atherosclerosis. So these are the two most common causes of ischemic stroke. First is the atrial fibrillation and second is the carotid atherosclerosis. Apart from these two major causes of ischemic stroke, there are other causes also which will be discussed later on. So first, the ischemic stroke. So the first mechanism is the cardioembolic stroke. So whenever emboli originates from the heart and goes to the brain, it leads to the cardioembolic stroke. And the cardioembolic stroke, it is responsible for 20% of all the ischemic stroke, and the stroke which is caused by the heart disease is primarily due to embolism of the thrombotic material which is forming on the atrial or ventricular wall of the left heart valves. So a thrombus is formed in the heart, and from this thrombus some part goes to the brain and leads to the cardioembolic stroke. And what are the main characteristics of the cardioembolic stroke? So first is the sudden onset. So first is the whenever the cardioembolic stroke occurs, will be the sudden in onset, and the neurological deficit will be maximal at once, and petechial hemorrhages can occur within the ischemic stroke. And this cardioembolic stroke, it most often occurs in the MCD territory or posterior cerebral artery or one of their branches, and infrequently the anterior cerebral artery is involved. We all aware that the brain is supplied by the main three cerebral arteries: anterior cerebral artery, middle cerebral artery, and the third is the posterior cerebral artery. The anterior cerebral artery and the middle cerebral artery, these are the branches of the internal carotid artery, and the posterior cerebral artery, it is the branch of the basilar artery. And the anterior and the middle comes in the anterior circulation, and the posterior cerebral artery comes in the posterior circulation. So whenever the cardioembolic stroke occurs, it usually involves either the middle cerebral artery or the posterior cerebral artery. Infrequently the anterior cerebral artery is also involved. So the most common causes of cardioembolic stroke are: first is the non-rheumatic non-valvular atrial fibrillation. So the atrial fibrillation, it is the most common cause of cerebral embolism, and the stroke risk can be calculated using a score which is known as the CHADS2 score. So if a patient is suffering from atrial fibrillation, and what is the risk of stroke in this patient can be calculated by the CHADS2 score, and according to this score there are certain recommendations that these patients should be given aspirin or the anticoagulant or not. So according to the score, these patients should be started on aspirin or anticoagulation to reduce the risk of stroke in these patients. So the most common cause of cardioembolic stroke is the non-rheumatic non-valvular atrial fibrillation. And other causes of cardioembolic stroke are the myocardial infarction. So the myocardial infarction leading to the thrombus in the heart, and part of this thrombus goes into the brain and producing the cardioembolic stroke. Prostrated valve, whenever there is some valve is the prostrated valve, so there will be chances of thrombus formation on these valves are there, and this thrombus can lead to the cardioembolic stroke. Rheumatic heart diseases or the ischemic cardiomyopathy. So these are the important causes of cardioembolic stroke. There may be atrial fibrillation, myocardial infarction, prostrated valves, rheumatic heart disease, or the ischemic cardiomyopathy. And there is what is paradoxical embolization. The paradoxical embolization occurs when the venous thrombi migrate to the arterial circulation. So the embolization is usually going from the left side of the heart, but in certain cases the embolization can occur from the right side of the heart, and this is known as the paradoxical embolization. But for the paradoxical embolization, you must have a patent foramen ovale or the atrial septal defect. So any thrombus or any emboli coming from the right side of the heart to the left side of the heart from the patent foramen ovale or the atrial septal defect, and this embolize and this thrombi go into the brain and produce in the embolization. So this is known as the paradoxical embolization. So as you already told you that the embolization can be the cardioembolic stroke when it is originates from the heart, or it can be a artery to artery embolic stroke. So whenever there is a carotid atherosclerosis, from the carotid atherosclerosis a thrombus is formed in the carotid artery, and part of this thrombus going into the brain and producing the artery to artery embolic stroke. So the thrombus formation on the atherosclerotic plaques may embolize to the intracranial artery, producing the artery to artery embolic stroke. And there are certain vessels which are more prone to produce the artery to artery embolic stroke, like aortic arch, common carotid arteries, internal carotid arteries, basilar arteries, vertebral arteries, and carotid bifurcation. So these are the arteries which are more prone to produce the artery to artery embolic stroke, and the most common source of the artery to artery embolic stroke is the carotid bifurcation, because this is the site where we will get maximum thirst of the blood flow and the maximum chances of formation of thrombi, and this thrombi can produce the embolization and producing the artery to artery embolic stroke. And it can be the carotid atherosclerosis when the atherosclerosis is formed within the carotid artery, and the risk factors can be male age, older age, diabetes, smoking, hypertension, and dyslipidemia, and it produces the 10% of the ischemic stroke. So the carotid atherosclerosis can produce the artery to artery embolic stroke, and the classification of carotid atherosclerosis is based on whether the stenosis is symptomatic or asymptomatic and what is the degree of stenosis. On the basis of these two factors, we can classify whether the carotid atherosclerosis is significant or not. And apart from the carotid atherosclerosis, which is the most common cause of artery to artery embolic stroke, there are certain other causes of artery to artery embolic stroke, like intracranial atherosclerosis, aortic dissection. So there may be a small vessel stroke. So apart from the artery to artery embolic stroke and the cardioembolic stroke, there are other common causes of stroke or also which are less common. So these are the hypercoagulable disorders, venous sinus thrombosis, sickle cell anemia, fibromuscular dysplasia, temporal giant cell arteritis, necrotizing granulomatous arteritis, primary central nervous system vasculitis, certain drugs in the form of amphetamines and cocaine, moya disease, reversible posterior leukoencephalopathy, leukoariosis, or CADASIL. So these are the less common causes of stroke. So now, a patient, how will you approach to a patient who seems to with ischemic stroke? So you have to approach the patient. So patient is coming to you with the stroke, and you have to now approach the patient. Then how will you diagnose and how will you treat this patient? So the patients with acute stroke often do not seek medical assistance on their own because they are rarely in pain and they may lose appreciation that something is wrong. So usually it has been seen that the attendants are bringing these patients to your side for the treatment, because these patients they are rarely in pain and they may lose appreciation that there something is wrong, which is known as the anosognosia. And so the sudden onset of any of the following: it can be the unilateral loss of sensory function, unilateral loss of motor function, changes in the vision, gait, speech or comprehension, or sudden severe headache. So a patient of stroke may present to you in any way of: it can be the impairment in the motor power, it can be the impairment in the sensory function, it can be changes in the gait, speech, vision or the comprehension, or it can be a sudden severe headache. So a patient may present to you with abnormality in any part of this, and there are certain neurologic symptoms which mimic the stroke. They may be in the form of seizure, intracranial tumor, migraine, and the metabolic encephalopathy. So these comes in the differential diagnosis of the stroke. And your clinical, now come to the clinical examination. Your focus should be on the peripheral and the cervical vascular system. But why we are focused on the peripheral and the vascular system? To found out the cause of the stroke. We should be focused on the heart, extremities, and the retina. So once a clinical diagnosis of stroke is made, a brain imaging study is necessary to determine if the cause of stroke is ischemia or hemorrhage. So first you have made a diagnosis of stroke, then we go for the brain imaging. Why the brain imaging is required? Because we are not sure whether the patient is having the ischemic stroke or the hemorrhagic stroke. To differentiate between these two, whether the patient is having ischemic stroke or the hemorrhagic stroke, we require a brain imaging study, because the treatment differs in both of these parts. In the hemorrhagic stroke, our main focus is on the BP reduction, while in the patients of ischemic stroke, our main focus is in the form of thrombolysis, which can be done either some procedure, that is mechanical endovascular thrombectomy, or we can be done through recombinant tissue plasminogen activator. So the CT imaging of the brain, it is the standard modality to detect the presence or the absence of intracranial hemorrhage. So whenever the patient comes to you with the stroke in the emergency department, first a clinical diagnosis should be made of stroke, then a CT scan should be ordered. You should not wait for the MRI, because the CT scan is very rapid, does not take time. Only just a few minutes is required for a CT scan, and we are mainly focused whether the patient is having a hemorrhage or not, because the treatment differs in both of these parts. So the patient should not be wait for the MRI of the brain. And then the medical management to reduce the risk of complications, then plan for the secondary prevention. So first we do a complete neurological examination to localize the site of the stroke. Then we go for an imaging study of the brain, which is required for the patient being considered from thrombolysis, ECG to find out whether the patient is having myocardial infarction or arrhythmias, and certain other tests in the form of chest X-ray, urine analysis, blood sugar, CBC, lipid profile, ESR, electrolytes, renal function test, PT, APT, and serology tests for the syphilis. So first we go for the CT scan. So identify or exclude hemorrhage as the cause of stroke, and they identify the extraparenchymal hemorrhages, neoplasm, abscess, and other conditions masking as the stroke. So you should go for the CT scan, and CT scan obtained in the first several hours after an infarction generally shows no abnormality. So if the patient is having hemorrhage, CT scan will you show whether the patient is having hemorrhage or not. But if the patient is having ischemia, some infarction, the initial CT scan done within the first few hours may not show any abnormality. So we have to go for another CT scan after 24 to 48 hours to find out the site of the ischemia. Now come to the treatment. How will you treat a patient of stroke? After the clinical diagnosis of stroke is made, an orderly process of evaluation and treatment should follow. And our first goal is to prevent or reverse the brain injury, and attend to the patient ABC, that is the airway, breathing and circulation, treat hypoglycemia or hyperglycemia, and perform a non-contrast CT scan, because no reliable clinical finding can conclusively differentiate between the ischemic stroke and the hemorrhagic stroke. So a non-contrast CT scan should be done. Now come to the treatment. So these are the categories of treatment in the cases of ischemic stroke. First is the medical support, second is IV thrombolysis, third is the endovascular techniques, fourth is the antithrombotic treatment, and fifth is the neuroprotection, then the stroke centers and rehabilitation. So our treatment is on these parts, the ischemic stroke. So first is the medical support. So our immediate goal is to optimize the cerebral perfusion in the surrounding ischemic penumbra. So whenever a ischemic stroke occurs, a certain part of the brain is that's infarcted. Infarction means irreversible damage to the brain. But surrounding infarction, there is a part of the brain which is known as the penumbra, and this penumbra is the ischemic part. It is the part of the brain which can be saved if we start the treatment on the time. We can save the penumbra from converting to ischemia to infarction. And attention is also directed towards preventing the common complication of bedridden patients, because usually these patients are bedridden, so we have to focus our treatment also to prevent the complication in the form of infections and deep venous thrombosis, that is the DVT. And if the patient is having hypertension, the blood pressure is lowered, but the blood pressure should be lowered only slowly. It should not be reduced very rapidly, because if we reduce the blood pressure rapidly, the part surrounding the cerebral infarction may get damaged. If the patient is having fever, the fever should be treated with antipyretics and surface cooling. We have to focus on the blood glucose. If the patient is having hyperglycemia or hypoglycemia, it should be treated appropriately. If the patient is having cerebral edema, it should be treated with either water restriction and IV mannitol. And watch out for the hypovolemia, as this may contribute to the hypotension and worsening infarction. And the cerebral edema can cause the obtundation or the brain herniation. If the patient is having a large infarction, if we go for the CT scan and the CT scan is showing that the patient is having a large infarction, in that cases we may require the hemicraniectomy. What is hemicraniectomy? That is the craniotomy with temporary removal of the part of the skull which reduces the motility. So it has been seen that when these patients go for hemicraniectomy, so chances of prognosis are better in these patients rather than those patients who's got only the medical treatment. Then comes our main treatment, that is in the form of IV thrombolysis. The IV thrombolysis can be done through the recombinant tissue plasminogen activator, but the treatment of IV RTPA should be done within 3 hours of the onset of ischemic stroke. If the patient is coming to you within 3 hours or up to maximum 6 hours, then we can go for IV thrombolysis. But if the patient comes to you after 6 hours, then the IV thrombolysis should not be done, because it has been seen when this patient goes for thrombolysis from the RTPA within the 6 hours of ischemic stroke, the mortality or the morbidity are chances of mortality are less. But if the thrombolysis is done after the 6 hours window period, the mortality becomes higher. So these patients should be gone through IV thrombolysis only when these present within the 6 hours of ischemic stroke. And there are certain indications or contraindications for recombinant tissue plasminogen activator. So what are the indications? If your diagnosis is stroke, the patient presents to you within 3 hours or 6 hours, and CT scan shows no hemorrhage, age is more than 18 years, and consent by the parent or the surrogate. Only if these indications are met, then only you go for IV thrombolysis. But we should also keep in mind certain contraindications which are attached with the recombinant tissue plasminogen activator. Like if the patient is having sustained hypertension, platelets are less than 1 lakh, hematocrit is less than 25%, glucose is less than 50 or greater than 400. The patient is having a hemorrhagic stroke, patient is comatose, if he has gone through major surgery in the preceding 14 days, or prior stroke or head injury within 3 months. So these are the certain contraindications which should be kept in mind before going for IV thrombolysis. Then the endovascular techniques. So vessels which involve a large clot volume and often fails to open with IV RTPA alone. So these are the vessels like middle cerebral artery, internal carotid artery and basilar artery. So it has been seen when the ischemic stroke occurs due to thrombosis or embolization due to these vessels, they does not respond to the IV thrombolysis. In these patients, we may go for endovascular techniques. So there are certain endovascular techniques like endovascular mechanical thrombectomy. So we can remove the thrombus through the endovascular techniques, which is known as the endovascular mechanical thrombectomy. And there is a newer device which is known as the Mercy, that is mechanical embolic removal of the artery endovascular technique, which can be also done in these patients. Then the antithrombotic treatment. This antithrombotic treatment can be in the form of platelet inhibition. So the platelet inhibition can be done through the aspirin, clopidogrel, axizimab, or the clopidogrel. And the anticoagulation. This anticoagulation can be done through the low molecular weight heparin. So this is the anti-thrombotic treatment. Then comes the neuroprotection. So the neuroprotection use of drugs which block the excitatory amino acid pathways, which protects the neurons and glia in animals, and hypothermia, which is a neuroprotective in the patients with cardiac arrest. So the neuroprotection can be done with the use of these maneuvers. Then there are certain stroke centers and rehabilitation which provides the rapid recovery of these patients. Now come to the prevention part. How will you prevent these patients from going to the stroke and TIA? So primary and secondary prevention of the stroke and TIA. So what is primary prevention? When we are given some treatment before the onset of any event. It is known as the primary prevention. And what is the secondary prevention? To prevent when the event has been occurred, but in the future this event does not occur second time, we are given any treatment, which is known as the secondary prevention. So apart from the treatment, our focus is also should on the primary and secondary prevention also. So first principle of the primary and secondary prevention is to control the modifiable risk factors. Any risk factor can be a modifiable risk factor like the hypertension, diabetes, dyslipidemia, or it can be non-modifiable risk factors like race, age, or the sex. So the we can control only the modifiable risk factors, but we do not can control the non-modifiable risk factors. So the modifiable risk factors or the non-modifiable risk factors can be in the form of older age, family history of thrombotic stroke, hypertension, tobacco smoking, abnormal blood cholesterol, prior stroke or TIA, cardiac conditions, oral contraceptives and hormone replacement therapy, hypercoagulable states, and the diabetes. So these are the risk factors. And how can you do a primary and secondary prevention? This can be done with the use of antiplatelet agents, and the commonly used antiplatelet agents are the aspirin, clopidogrel, ticlopidine, and the dipyridamole. But the most extensively used and most extensively authorized agent is the aspirin. And this can also be done through the anticoagulation therapy in the form of the oral anticoagulants. Now come a certain word about the TIA, that is the transient ischemic attack. So what is the meaning of transient ischemic attack? So the patient is having an attack, but it is only transient, and the episodes or stroke symptoms which last only briefly. And the standard definition of duration is less than 24 hours, but most of the TIA lasts less than 1 hour. So this patient is having a focal neurological deficit, but it comes suddenly and it disappears rapidly. So if the patient's focal neurological deficit must recover within 24 hours. If it does not recover within 24 hours, it does not come in the category of the transient ischemic attack. Only when the patient's focal neurological deficit completely recovers within 24 hours, then it is known as the transient ischemic attack. Now, so after the ischemic stroke, the patient may have a hemorrhagic stroke also. So the hemorrhages are classified by their location and underlying vascular pathology. So hemorrhages may be in the form of subdural hemorrhage, it can be epidural hemorrhage, or it can be a subarachnoid hemorrhage, or it can be intraparenchymal and intraventricular hemorrhage. So when the hemorrhage, So this classification is based on the location and the vascular pathology. So, and the most common type of hemorrhage is the intraparenchymal hemorrhage. So when the hemorrhage occurs within the brain parenchyma, it is known as the intraparenchymal hemorrhage, and it is the most common type of hemorrhage. And the major causes can be the hypertension, trauma, or the cerebral amyloid angiopathy. And the risk factors can be the advanced age, heavy alcohol consumption, or the use of certain drugs like cocaine and methamphetamine. And how you will diagnose the intracranial hemorrhage? It can be diagnosed through the use of non-contrast CT. So intracranial hemorrhage, it is often discovered on the non-contrast CT imaging of the brain during the acute evaluation of the stroke, and CT imaging is preferred method for acute stroke over the MRI since it is more sensitive on the acute blood. So we can safely diagnose the intracranial hemorrhage with the use of non-contrast CT. And our emergency management, you should focus on the ABC, that is the airway, breathing and circulation. Usually this patient comes to you with the sustained hypertension or the accelerated hypertension. So our main focus is also on the use of antihypertensive to reduce the blood pressure, and this blood pressure can be safely lowered using the nicardipine, labetalol, or the esmolol. And the mean arterial pressure is maintained less than 130 millimeter mercury unless an increase in the intracranial pressure is suspected. And if the patient is not in the good shape, it is comatose, we can go for the tracheal intubation, mannitol administration, hyperventilation, or elevation of the head of the bed. So this is all about the stroke or the cerebrovascular accident.